Great. So we said we are starting with storytelling. And we want to hear first from Dr. Maina. Gentlemen, in this case first. And this session will be focusing on intentional leadership for quality improvement and patient safety, right? And we have leaders in that space here on the panel. And so we want to hear first a story about their journey, how they have built a quality improvement and patient safety program in their hospitals. This is at facility level, how that implementation has gone, how it started, and where it is now. So really a story that tells us, the nuances of how that went. Karibu.
Thank you very much. Good morning, everyone. It's always a pleasure to sit in this precious seat in front of such distinguished people in the quality space. As you've heard, my name is Watson. I just go by Watson. And I am truly honored to be here. My journey personally in quality is what you'd call a sequence of serendipity and sort of stumbling forward. And my story is one of just opportunity. Because being in Kijabe, I got a lot of exposure to quality without having a name for it, without knowing that there was like an intentional thought behind how we were doing things. And that's how I got exposed, that's how I got mentored into quality. So even when I transitioned into leadership in the quality management department, I was not formally trained in anything about quality. However, because I had been in Kijabe for quite a long time, it was already something that I was experienced in. It's something that we were doing and living and breathing. And so I'll just share briefly about our history and how that came about. So around 2015 was our first sort of formal foray into the quality improvement space. We had a community health team in Kijabe Hospital doing the IHI cohort, the IHI training program. They were the first to do it in Kijabe. And slowly by slowly, even as they got educated and trained in the quality improvement science, they began to influence people in the community and in the hospital, just slowly by slowly. About 2 years later, we had a major, let me say, titanic moment in Kijabe Hospital, where we were facing big issues that almost led to the hospital closing down. And because of that, there was a major shift in how things were being done. So this is on the administrative or like hospital management side, but its impact in how we provide quality care to the patients cannot be understated. And so that led to a system change that first began with a change in our leadership and a change in our governance. From that time on, when the leadership changed, we had the professionalization of the board. Previously, the board was not structured in a way that was not like structured by technocrats or professionals, though it served very well. But at this point, there was a deliberate decision to make sure that the board was made of professionals. And that is when we first had our medical quality and training subcommittee at the board level. And the chairperson is actually present with us. I don't know if I should mention their name, but so that's what happened at that board level. And the leadership of the hospital was deliberate in making sure that we have quality improvement, or quality as a way of doing things, in the way we provide care, in the way we relate to each other, in the way we take care of our staff. Because if you take care of your staff, then your staff will take care of your patients. I think it's invariably connected. And so after that, we had the official introduction of the quality department, and our first quality manager was actually a trainee from one of our residency programs in Kijabe. And I say this to point out that while on a systemic level and institutional level, the structural changes were occurring, on a more frontline and ground level, quality mentality was already being inculcated in us. Because, so her name is Faith. So Dr. Faith, when she took over, she had just finished the residency program in which quality improvement was a required unit. In Kijabe, it was the first time the program was being done in Kijabe in collaboration with Kabarak University. And so you see how that converged into, for such a time as that. And so when she took over, that is exactly the time when COVID hit. And so COVID hit the country, and as Kijabe Hospital, we found ourselves prepared to be adaptive to the stressful situation that COVID introduced. So many things, it was basically a chaotic domain. So many things were up in the air, but we were able to adapt continuously through the entire process under the leadership of the hospital, the quality department, and the responsiveness from the staff. And I'll actually give an opportunity to someone to share that story. And so even as we proceeded on, we had more and more interest from staff to do quality science training. And so we partnered with Stanford to do quality improvement training, and we had several teams, including our senior leadership. The medical director, the head of surgery were actually part of those trainings, and we had about, I think, 7 or 8 cohorts or 7 or 8 teams. And they're all responsible for various things in the hospital, from improving TAT in theater, to improving how admission is done, to just various things in the hospital. And so after that, currently, we've had 2 cycles of IHI-trained nurses go through the program. I think there were 4 teams of 6 in one of them, and 5 teams of 6 in another. And that is how we have been slowly building up critical mass. That said, I think the most important thing about Kijabe, or about our experience and quality, was the culture question. Because as I mentioned earlier on, we had a huge shift in how things were being done in Kijabe. And we actually had a systems audit done everywhere, in everything that we were doing. And this led to a major culture change process. Chris Mandere was here yesterday, and he actually mentioned it. And this was instrumental in how we ended up doing things, because we identified the values that we want to embody, and we identified the way we want our patients, our guests, to view us as Kijabe. And that cannot be separated from the quality discussion. If your staff have buy-in and there's culture amongst them, then they can be able to deliver quality to the patients. And so I have a few examples, but I will actually just give an opportunity. I don't know if I can tell them at this point or later on. 2 minutes at this point. Yeah, so I have some colleagues amongst you seated there. We have Simon, Chris, and Caleb, who can share at least a story about a quality improvement project we had in Kijabe, just for 2 minutes, so that you can hear that it is not only top-down leadership, but there's a bottom-up ownership from the teams.
A minute each from them.
Yeah, I come from Kijabe. I'm Simon. During COVID season, we work in communities, but we were requested to respond during COVID season. And since there is an outbreak, we were forced to go and work in the hospital. So this time we asked, what should we do? And which assignment should we do? So we did, we were doing debriefing for staff. And during COVID season, this is a rapid response cycle. It's a quality improvement project. What we were doing, we asked to staff 2 questions. What is your current coping mechanism during the outbreak? And then the other question was, how do you want Kijabe Hospital to support you? So we did this every day. So, and we used to use flip charts and sticky notes to pick responses from all staff from various departments, and they would give us all kind of answers because it was new. No one had answers for COVID. And they would all give us their fears, their worries, and also what they would like management to do every day. So, and then the management would pass by in the evening and pick all answers of what they would like to be staff, like what they would like the management to do for them. So, and then the next day, the management would act immediately and respond immediately by changing the system and changing everything and giving instant answers to some of the challenges that our staffs were passing through. So, and this is an article that is already published. You can read through so that I don't take much time. And we would get some of these answers. We don't know how to wear PPEs. We need management to train us to wear PPEs, and that would be done immediately. There are various answers. We need people to be screened. We are not screened, and then that would be done immediately. We need someone to address our issues with our families, because we are concerned, because we are mostly in the hospital and our families are struggling. So something would be done to allay their fears. Some staff who got COVID would scare others. And then the management would respond by instituting mechanism to support staff. So there was immediate feedback, and this was done every day. So that's our quality improvement project during COVID season. I would pass this to.
Yeah, another project we did during that time, before we now went into the period of revolution, the dynamic changes that happened, the patient was not at the center of our discussion. And so whatever we proposed was management-led discussion. We want to build a house, we want to do 1, 2, 3, but we never put the patient on the focus. And so all the patients who came to the general outpatient would wait for 9 to 12 hours a day, and that was not good. They complained a lot. And so when we sat down, the QI started, which was a QI project, we realized that we need to listen to the patient. They can't be coming every day. They sit in the waiting areas for 9 to 12 hours, and you don't do anything about it. And so we started the project of changing that and improving the TAT. So in 2017, and going back, it was 9 to 12 hours. We had 12 steps a patient will go through. And some of the steps involve the patient going back to the same service point twice or 3 times, which was not good. We call that a spaghetti flow. So we dropped the steps from 12 to 6, but that was not easy. We had to involve different teams, sit together, discuss, ask them, what do you think we need to do? Why do you think a patient need to go back to a cashier 2, 3 times instead of going to the cashier 1 time and finish the flow? Why should the patient, those questions we ask ourselves. In 2019, we achieved 6 hours. In 2021, we achieved 4 hours. Our target was 3.5 hours for our waiting time. In 2022, 2023, we were at 3 hours, 30 minutes. Currently, with the 6 steps or so, we are doing between 3 hours, 30 minutes to 4 hours, 30 minutes for all the patients who come to Kijabe for visit. And that changed the experience of patients. And again, it reminded us to put the patient feedback in every discussion that we have. Thank you.
Okay, round of applause. Let's pause there for a moment. We've had a snippet of that Kijabe story. I think for more you've seen who that Kijabe team is. There's lunch and networking. We've had a snippet. It took a crisis to bring a wake-up call. There was engagement up to board level. And then there was also a healthcare worker engagement, right? And there was culture. There was a mention about culture change. That's what it took to begin that journey, yeah? And we've had a little bit of the outcome there from the team. So I'd like us to switch a little bit now to the KNH story. Kenyatta National Hospital, the national referral hospital here in Kenya. Let's hear about the patient safety initiatives there. How did it begin, and what's the journey been like?
Thank you. Thank you very much. Good morning. Is it still morning? Good afternoon. The KNH journey. Kenyatta National Hospital journey was not a one-day journey. It's been a journey of years. And I'll start back. Before I go to patient safety, I'll start with the quality improvement journey. Quality improvement journey, from the time I was employed by the institution, started way before 2015. I got employed in KNH in 2013, but in 2015, we had a major shift. The then leadership that was in the hospital, the management, opened doors for partners. And that time it was GIZ. And a few members of us were selected to go for a training. It was my first time to hear about quality and quality improvement. I mean, this was never taught in school at all. And so with Dr. Maureen Afula, we went through several sessions, and the joy that journey brought was the fruits that it brought. And one of them was the renovation of the accident and emergency department. And just like as Mandera said, they went around and drew the graphs, and they saw the spaghetti, the movements that the patients were making very unnecessary, the non-value add that was there, and some of the processes were totally not for the patients. They were our processes and not for the patient. And so through that initiative, a lot of fruit came out of it, and that's the time now the interest started peaking. And as I sit here, I'm a student of many of the teachers in this room. My teachers are in this room, the people who've walked that journey of quality with me, people who've explained quality in a language that I understood, and in a language that I still understand and I still carry with me. One of them is Peter Mutanda, who's seated here. He walked this journey with us in 2018. He supported us in having quality improvement initiatives, 2017, 2018, in 8 departments. Real issues, where we're talking about simple things like vital sign monitoring. Are we doing our vital signs for our patients? What are the challenges? Why are we not doing this? Are we monitoring our babies when we admit them? Are we having a standardized way in which we are admitting our patients? They were the simple things, but the impact of those simple things were very big to the patient. He never brought in concepts about big medicines or big instruments, just what you're supposed to do every day. And that is the change that came out of that. And so through that initiative, we were able to get monitors. We were able to show the leadership the case, build a case for why do we need investment in these resources. And so we were able to get monitors in most of the departments, and there was that initiative that carried on. I'm also a student of Dr. Kandie. who I've listened to over and over and over, and I never get tired of listening to him talking about quality in the country and the quality model for health. That is a journey that we need to revive, we need to pick, we need to continue with. I'm also a student of Dr. Okutoi and many other teachers in this space. And so to the journey of patient safety was always there, but we gave it a name in 2018 after a crisis. February 2018, if you go back in history, I know somebody mentioned it the other day that they saw it in BBC. They remember that story. We had something that triggered us to change the way we do things. And so that's how Patient Safety Department was born. So it was not an intentional birth. It was a painful journey and a painful experience that led to quality being embedded seriously and be taken seriously in the institution. So what have we done so far, or what has happened so far in those 5 years? At the beginning, there was a lot of, as we say, lack of understanding for all of us, including myself, and including the people I was seeking advice from. And we were trying to figure out, what is this? What are these concepts? And so we'd read what is being done outside Africa, because there was very little coming from Africa, to try and find out what can we do different in our setup. And so at the beginning, where we started was looking at the 8 indicators for patient safety, because that was the measure we had. And we embarked on a survey to find out, where do we measure as a start, just to find out what is our baseline. Because for you to improve, you have to know your baseline. For you to have quality improvement, you have to know your data. Where are you? So that you understand, where am I starting from this journey, and where do I want to go? And so we embarked on a journey of understanding what is our baseline, where do we start, and using that indicators, we're able to measure and see where we were in the various indicators that we had. There were some that we were underperforming. There were others that we were average. Hospital-acquired infections, IPC measures, we were average because we'd started that program earlier on. But there's some indicators that were totally, we had not started at all. And so having that baseline data has helped us in this journey of 5 years to try and understand this improvement. And with the data, it helps us reach out to the management. Sometimes for you to get quality improvement embedded as a culture or as a way of doing things, you have to build that case. You have to prove, you have to show, because there are many other competing interests in the institution. We are thinking about surgeries, we are thinking about medicines, we are thinking about vaccines, we are thinking about everything else. So this thing that you're talking about, quality improvement, you have to give it a face and you have to give it justification as to why it needs to be embedded and why it needs to be considered as important. So as we speak right now, when we look at the 7 pillars of clinical governance, I would want to say that all 7 pillars are embedded at Kenyatta National Hospital. Starting with patient involvement, we have a patient affairs department, and we have patient and family involvement. All the patient experience measures that were mentioned in the morning, that is culture. We are not yet there, but we are going somewhere, or we are somewhere right now. Clinical audits are a way of life at KNH. Departments do their clinical audits, they monitor, they measure, they see how to improve without a lot of push from the management. People have owned that process, and so that happens on a quarterly basis. It is in our performance contracts. Staffing and staff management, this is something in clinical governance, but it is a pain point for us, and I think across Africa we all feel this pain, especially of the mass exodus of staff. I don't know how we are going to retain our talent in this continent and how we are going to make it attractive, but the exodus of talent, experienced staff is a challenge that we're experiencing, but it's one of the things that we could say at least we've seen an improvement in staffing ratios, and we're still trying to see how that can be embedded in terms of our culture. Clinical effectiveness, every department in KNH is mandated to have this as part of their targets or as part of their core mandate. And so as they develop their protocols, as they develop their guidelines, as they develop any document that they are going to use and share with their teams on how we do things here, that is one of the things. And together with the research there, supporting them in that clinical effectiveness measure. Risk management and safety. In patient safety, we do clinical risk management. We have our quality assurance department that does risk management, and we also have the Department of Risk and Audit that also does risk management. And then data and information, as we were told yesterday, that's a gap that we need to bridge as African countries. Our data sometimes is not the best quality data that we have, and so you can make very little inference to it, but it is a point that we can improve on, and it's something we can work on, especially for facilities that we still use manual or paper-based systems. We could seriously improve on our data and information system. And then in terms of education and training, as we said, education, when it comes to quality and safety, we did not get that in our education or in our foundational courses. But I'm happy to hear that Kijabe has that in their foundation courses. So what have we done in KNH? We've developed curriculums. It might not be at the postgraduate, undergraduate level at the moment, but in our training and research center, we have a patient safety curriculum, and this year we developed a patient and family engagement curriculum. And so we are waiting for NITA to accredit them, and we can start rolling them out for people to start learning, and we start small as we grow. So far that has been a journey that we've undertaken. And for us to achieve this, there's been a lot of need to understand from the frontline level, leadership level, and the middle management level. If you understand the journey from only one perspective, you might lose the other team. And so it has helped us, or it has made us to be able to get down to the ground to be very relatable. Otherwise, it is very easy to speak about very big WHO things up there, and when you come to the ground, people cannot understand what exactly are these people talking about. You'll bring very nice policy documents, and it will be very difficult to implement. So it has enabled the team that I work with to be able to translate and break it down into a language. When we talk about patient experience, what is this language that we're talking about? How do we enable, or how do we explain to the doctor, yes, you have 40 patients. We understand and we agree you have 40 patients in that clinic. And after that clinic, you have a theater that you're going to. But out of these 40 patients, it's 40 experiences. And you can still find time to say, how are you? Good morning, my name is Dr. So-and-so, as you find out the patient's name. It is possible. It is something that can be done. And so that in brief, I don't know if I've answered your question in depth, but that's in brief where we are at KNH. We are still on the process of learning. We are not yet in a position to say we've arrived. It is a journey, and that's just a brief of 5 years. We don't know when, call us after 10 years where we will be, but we hope we'll be somewhere better and we'll have grown and matured in this institution. And so,
thank you, Dr. Kalondu. Fantastic to hear how that journey has been, and you have been a part of it the whole way. I have just one follow-up question for each of you, and then we'll hear from the team in the room and in the online platform. Just one. Dr. Watson, leadership buy-in. Big deal in implementing quality improvement programs at facility level. What did you do? In summary, in a minute or so, if you could just summarize what was the most important thing to get buy-in from the leadership, and was it important? Was it important for you to be able to have a successful program?
I think there's someone in the morning who mentioned that one of the most important things for leaders in our facility is, I think you said money, or So it's basically the sustainability of the institution. They have been tasked with that responsibility. And in short, the answer is yes. Leadership buy-in in quality is not something that is breaking news. This is central to the quality agenda. And I think for Kijabe, as you've heard, which is a similar story to KNH, is when the sustainability of the organization is very clearly connected to being to the quality agenda, it brings their attention and it begins to make sense to have focus and resources directed to making sure we have quality. Unfortunately, for some reason, quality is seen as in some circles, is seen as that thing over there. And part of the work that we all have to do is to make sure that it's not an add-on. Quality is not cherry on top. Quality is everything. Quality is the flour that you'll use to make that cake. Quality is, without quality, we cannot talk about having a facility. Otherwise, you are not, you're not doing your very core mandate. So for Kijabe, the circumstances triggered a big institutional change and quality buy-in, leadership buy-in. But that happening at that level was met with slow build-up of the quality perspective in the way we delivered care. So in the clinical space, you'd find the way we mentored each other. We mentored our interns, we mentored the younger clinicians. How I was mentored was, it was common practice in the morning before ward rounds. So we are a faith-based organization. So we'd pray before we started. And we'd introduce ourselves to the patients, ask them about their family, their experiences. And this is during a ward round in the morning, where, as we all know, ward rounds, you have little time. And for example, in surgery, to be able to do that and still do surgeries, we did our ward rounds at 6 a.m. And there are people who'd come to Kijabe from other facilities and wonder, why are you having ward rounds early in the morning? And so that connecting quality to the core agenda is how leadership buy-in, how we were able to achieve it.
All right, I like that, connecting quality to the core agenda, for buy-in. Dr. Kalondu, healthcare worker engagement. We heard from the keynote speech that, one of the things that ails us is workforce disengagement. What was your approach in summary, and was it important, and how will it be sustained? Sorry?
Can I bring in the online people?
Yes, let's
that we respond to their questions together. I simply want to do what I didn't do earlier. I want to acknowledge that we had a challenge in the morning, and now from about 11 o'clock, we've had a fantastic Zoom meeting. So greetings, let's say hello to the 163 people online. We are really, really grateful that you're there. So just let me quickly take a few comments, as I did yesterday. So we have some, I can see Jolande, Noladebo, those sound like very Nigerian names. I can see they are saying from Victor Johnson General Hospital in Lagos, Nigeria. We are very glad you're online. Now let me get to the questions. Elizabeth Kamau says, well done, Kijabe. What you did is to get the voice of the customer, and management responded to this. Healthcare should do this diligently. So the question is, in your second project, you reduced waste. Great initiative. Oh, okay, that wasn't a question, it was just a comment. So now the question to Kijabe, how do you monitor implementation of the developed policies, procedures, and guidelines? That is the question from Elizabeth Shonko. So we say, I can see someone else from Lagos State Health Service Commission talking about good job. They have done the same thing there with mother and child health. So I just want to acknowledge your comments. Now, people online, we will be giving you a chance to raise your hands and speak. So the moderator will alert and give you a few moments. If your hand is raised, we'll give you the opportunity to talk. If there are no hands, we'll proceed on to the next session. So let me go back to you.
Right, so Rhoda, you can answer the previous question and then we'll go back to Watson for.
Okay, so the previous question was on health worker engagement. Was it important? Very, very important. That's the most crucial thing you'll do in your QI journey and in your patient safety journey, any quality journey. If you don't engage the staff that are supposed to deliver that, you'll have lost that journey, you'll have lost that battle as you start. And it's not a battle, actually. When you call it a battle, it sounds like you're fighting. No, we're not fighting this journey. And so for us, it was very important at the beginning, and it still remains important. We had challenges. Remember, this is not something that was our nature. It was not our culture. And so change management, culture, change of culture, that was very important to us. And you had to reach to the different teams in a language they understand. To engage me and to engage you, it has to be a language you understand. If I engage you in a language that you don't understand, I'll be talking to, it will just pass with the wind. I'll just be talking and it won't have an impact. It won't pull your heart towards it, towards that initiative. And so we had to get to a language that staff understand. We are not yet there. And I'll keep on repeating this because it is not an easy thing. It's not something you wake up and you do tomorrow and everybody's towing the line. In a facility with 6,000 staff, and that's without counting the students who are part of our complement, and the students, we have quite a big number of students, undergraduate, postgraduate, who are part of us. So changing the mindset, changing the culture, changing the narrative, changing the behavior has not been something easy, but we continue engaging our staff, and we do this through training, continuous training. We do this through visiting them at their workplaces and engaging them, talking to them and finding out. Even as we bring in a new tool, as we bring in a new policy, as we bring in a new guideline, there's need to hear from them. So stakeholder engagement. And stakeholder, apart from the patients and their families, the staff are the biggest stakeholders. They're the ones who will drive that change for you. The change that you're looking for in your facility will be driven by the staff. The patient will be the beneficiary of it, but if the staff don't buy into it, it will remain your project or your initiative and the patient. And so that has been a big thing for us. So whatever document we develop, any initiative that we have, any tool that we have, we try and sound with the teams. The good thing about the department that we work in, the quality department, we have a team that are healthcare professionals. And so they understand because they've been on the ground before. We've worked at the ground level. We can relate, we can understand, we can appreciate, we can empathize with the teams that are there. And so that has been very important to us. The other way we've engaged staff is by offering psychological safety. I know that came out very clearly yesterday. Without psychological safety, there'll be no opening up. There'll be nobody will be telling you anything. And so how have we done this? Initially our processes were paper-based, especially when it comes to incident reporting. We have two ways of reporting incidences at the hospital. There's the one that is through the nursing division, and that is paper-based. And then there's the one for patient safety. We hope at one point we'll synchronize them and only have one channel of reporting. But at the moment, those are the two structures that have been there. The one for nursing incident reporting has been in existence for long. The one for medical error or clinical error reporting or any incident reporting started in 2018 when patient safety unit was formed. At the beginning, we had a lot of fear. There was a lot of fear. If I report, am I reporting my colleague? If I report, what happens next? If I report, am I going to be asked to step aside for investigations to happen? So yesterday when I was listening to the room, I was remembering that journey that we've taken. And so what did we do different? We realized that having that process change, a slight change in the process, might open up doors for us to understand what are the areas we need to engage staff more and we need to change the system. And so we developed an online medical error reporting tool, completely anonymous. If you want, you can identify yourself, but it is very anonymous and it's voluntary. So in this process, there's a QR code you can scan, fill in the tool, tell us what happened, and it's a very simple, within 1 minute you can fill in that tool, and it prompts us to come and engage your teams at the ward. So we made it easier for people to reach out to us. If there's a wrong blood transfusion and it is keyed in there, it is very easy for us to see and identify and go and find out what happened in that ward, pay a courtesy call and try and do a root cause analysis with the teams. At the same time, we've supported a few departments that have developed their champions. There are a few areas where they decided we want our own champions. And so we try and support them just to understand that we are working in this together, and it is a transparent system, and we are here to improve this system. And so that has been part of the engagement process that we've had with our staff.
Thank you. We are now going to be going into the session where we take a few questions from the plenary. And at this point, I invite the gentleman the two gentlemen on those tables. We'll take about 4 questions.
Thank you. Thank you, Dr. Rhoda and Watson. I want to give my question straight to Dr. Rhoda because you're more of a patient safety expert. My name is Arthur Egulu. I come from Rhoda Hospital. I serve once again as a quality assurance manager of the hospital. It's a second oldest hospital in the country, and we implement the COSASA standard of accreditation. We have just been accredited by COSASA, and it's a journey that we undertook starting 2019. One of the opportunities that we have had with our staff is that they've come to know about the standards, and ideally this one has helped us to standardize quite a number of processes. We have several challenges, and they speak to patient safety, and specifically I want to draw our attention to the hospital-acquired infections, where we have had challenges. Earlier on, we didn't have particular definitions of what patient HIAIs mean, and we're basically handling them in terms of percentages, everything percentages. And for example, when you talk about the IV infections, how many infections have we had in a month out of the number of patients times 100%? However, we got correction, and we had to fine-tune ourselves to international patient safety definitions. However, we are finding it hard at the facility to inculcate the culture of data collection in our facility. So the question comes to the fact that how do you consistently capture your data based on the indicated definitions in the different units? Rhoda Hospital is a 240-bed hospital, so it's has a number of specialties in the hospital. That is the first question. My second submission is an opportunity to us all who have gathered in this place for the last 1 day and now, that the discussion of healthcare-associated infections deals with more of data. And one of our themes this afternoon is using data to systematically make improvements in healthcare. And the opportunity I'm trying to put across is that we're a community of practice in QI and patient safety. Can we open our minds to coming up with something of having an opportunity to share our data, share our tools that we use in the different aspects of definitions both in quality and patient safety. For example, when we talk about surgical site infections, what is KNH using? What definitions are they looking at? How are they collecting their data? Can we have them present to us on how they analyze their data? How are they visualizing their data? That way you have several hospitals coming on board. You have KNH in Kenya here, you have Kijabe, you have Rhoda Hospital in Uganda, and all other hospitals around Africa coming together, maybe a monthly basis or quarterly basis, coming to listen to this data. That way we end up creating an opportunity for all of us to improve.
where KNH is not where Rubaga is not where Kijabe is. We're all at different levels, but when we bring up this community of practice, of data sharing, and making tremendous improvements in how we do it, explaining to staff consistently that this is what you do, because a nurse will not think about the data itself, but you in management, basically you'll have to say, you find better ways of how you need this data. So I want us to open up this opportunity, and I think we can have this as a way forward on how Acquire can proceed if we want to inculcate the culture of patient safety and quality in Africa through data sharing. And we can make it more practical, have the quarterly sessions where a particular hospital can present, they present their tools, their data, analyze their visuals, and maybe tell us the best practices. That way we're able to share best practices across the continent. Thank you very much.
The gentleman in red on the table, yes.
Good morning all, and thank you, the panelists. I personally know Dr. Watson. I met him 2015 in Kijabe, and I want to thank the team for the presentation that I appreciate, and I want to applaud the method you guys introduced during the COVID. I'm sure that all of us here were involved in managing COVID at the time. It is important to share why, because it was an outbreak, and we don't know when the next one is coming. So hearing like this, we better prepare for the next one that is coming. Thank you so much. I want to also say that about updating patients or having patient conference to update them. I have been doing that a lot since 2015. I learned from Kijabe, and we can already see from here that Kijabe is doing a lot. Something that is good to copy. I really want to ask who initiated and was driving this this project where you ask the patient, where you ask the staff in trying to know what you can do for them, how they feel, and how was it to implement? How did the administration support this process? My name is Dr. Tumi. I come from Bingo Baptist Hospital, Cameroon. Thank you so much.
Thank you for your question. Let's take another one here in this middle table from the lady in green.
Thank you so much, Dr. Watson, and also Dr. Rhoda, for the very good work. It's really encouraging and motivating to us. So my question would be just on the frequency of collecting the patient experiences, owing to the fact that you have really diverse clients from all over and a lot of referrals to your facilities, and probably the issue of the language used, because I believe all those facilities have different clientele cutting across the nation. Then I think something that Dr. Tumi has already alluded to, also how are we getting to let the clients know that actually we utilize their feedback, because probably I was referred there today and the next day I'm gone. So how have we gone through this? I've seen in most cases for facilities that I've been working with, as we collect client feedback, we give an option. They can opt to give their number or not, and some don't actually give their numbers. So how have you gone about this? Otherwise, thank you so much.
All right, so one last question for this round of questions from that table there.
Good afternoon. My name is Ruth. The first question has already been covered. I wanted to know about the issue of the interpreters, because you have a lot of clientele in your hospital. So I wanted to know how do you deal with that. So the second question, is on the issue of the medical errors reporting, that we say that you are doing it online. That goes to Dr. Rhoda. So on that aspect, I wanted to know who is involved during the investigations. Like you are saying that this is an anonymous thing. So who is involved during the investigations? Thank you very much.
Okay, let's take those answers. First, let's begin with Dr. Watson here. Some questions from Dr. Tumi, and one.
Thank you for those questions. I think, so I'll go to Dr. Tumi's question about during COVID and how feedback was collected from the staff and how support was given to for the entire project. So I think by that point there was already very clear understanding that without leadership support there can be no meaningful or sustained progress when it comes to quality improvement. I don't think I can understate that. Is it understate? I can't overstate that enough. Very, very important. And so what happened was, in terms of support, as Simon very aptly put it, is that first there was actual dedicated time given to have these debrief sessions. You can imagine being given that time when the staff, a mixture of staff, different groups on the various days, have an opportunity to go and actually sit down, and you can switch off your phone. You won't be called away, right, for this 30 minutes or 1 hour, and you have this session. The sessions involved debrief because the staff themselves were undergoing a lot of stress. And so providing that opportunity for staff to debrief and to give suggestions and feedback to management regarding what they feel needs to be worked on and improved, that dedicated time was very valuable. And that's how the support was done. And then, of course, responding. Because it's one thing to hear from staff that you should do this, and then it's another thing to hear and respond in a way that the staff see that their suggestions are being taken. So those two ways, I think, were the key ways that this was done. Some of the suggestions, of course, involved resources, getting more PPEs, better training, changing how the patient flow was going. Even when it came time to ask staff to self-identify those who are at risk and cannot take care of patients who have COVID. That was done, and staff felt like, if I'm at risk, I have, there was a whole series of ways that at-risk staff should be identified. That was also done, instead of forcing people and saying, no, you have to because, we are short-staffed and things like that. So I think that kind of support was well felt and very necessary. There was a question regarding the frequency of collecting patient feedback. I guess to both of us, and Dr. Kalondu will also answer. So what we've instituted in Kijabe, and Chris, you can find Chris and get more information, is daily huddles. We have daily huddles in outpatient, daily huddles in inpatient, and these are nursing-led, but they're multidisciplinary, so that someone from finance, someone from radiology, someone from the lab, someone from physio, basically all the departments, come and meet together for 15 to 30 minutes, and then you go through a series of very simple questions. What went well, what went wrong, and how can we improve? Are we well staffed? And then any issues that arise. Those daily huddles have been providing very good basis for rapid response to patient feedback, because patient feedback would come through that. The other way is that there is, so the senior management team this was instituted back when we had this major change. It was actually responsibility of the senior management team to personally collect feedback alongside other channels, because we also have an online, like a digital channel. But for the sake of SMT, to get a feel of what the patients are saying and not just data on a page, they were tasked to, I can't remember the number, but every week or every month, 5 every week, to talk to patients, talk to them. There was a series of questions that they were meant to memorize, not just go reading from a form. Then get the experience from the patient. And this was very valuable because it led to a lot of improvement. When you hear that the patients are going through this kind of problem and it happens regularly, by the time it is discussed in a senior management team, there is already buy-in because you've received that qualitative feedback from the patient and not just numbers on a page. And then, of course, we had the regular patient feedback collection that was done from our social media spaces, from digital platforms. And so it was a mixture of all of that that led to a very rich data for improvement. There's another question from the online platform about monitoring projects. So the perspective that we have is to convert projects to become the new normal so that it's not just a project, it's just the way we do things now. And I've mentioned hurdles already and the continuous patient feedback. One of the things that has happened recently, and again, so this is the second time, is incorporating such quality mindset into the strategic plan of the hospital so that it's actually the hospital's agenda to have quality improvement. And everyone is required, all the way from the senior leadership to the front line in every department, both clinical and support, to have an element of quality improvement in their work plans. We, in 2019, transitioned to a fully digital system, and so we have very deliberate and streamlined way of collecting data. And so having data systems as part of the regular reports that senior management get is one of the ways that we also monitor these kinds of improvements. And Chris has mentioned about our TAT, and the reason why we have even those numbers is because that's something that the senior management team looks at every month. And cascaded down all the way to the front line, that's something that they're required to look at every time, and so you can be able to respond. We also have feedback to staff so that they hear and understand the kinds of things that we're doing. Yeah.
Thank you very much. Thank you for the questions. Congratulations on your accreditation. It is not an easy thing to get accredited. It's quite a journey and it's a long process. So congratulations for that. And I'd also like to congratulate you that you've started somewhere. Just measuring something, start something. And the fact that you've started hospital-acquired infection, or yesterday we were told to refer to them as healthcare, not hospital, is a plus. And so, and it's good that you're also implementing corrective measures once you identify a gap or once you identify a problem in the data or in your processes. So how have we maintained consistency in data collection at Kenyatta National Hospital? There are 2 ways in which we've done that. So I'll start with the hospital-wide, consistency at the hospital-wide level, and then I'll come to patient safety. So at the hospital-wide, just like Dr. Watson has said, in the facility, there's the strategic plan, and then there's the performance contract. The performance contract is drawn every year at the beginning of the financial year, and it monitors your work throughout that year. And some of this work has been cascaded. The data, remember I talked about clinical audits? They've been cascaded to departments, and so there's that drive also from the management that we need to monitor this data. We need to collect this data consistently. And we need to be measuring and seeing, are we adhering to our protocols? Are we adhering to our guidelines? Are we adhering to the processes that we've put in place? We also have another system, which is the Quality Assurance Department, which does the internal quality audits. And through these audits, they're able to see how are we adhering to our processes. So part of consistency also requires a monitoring check. Is there another party that is checking that the data you're collecting Is it making sense? Is it helpful data? Is it data that can be used for improvement and for decision making? So the data from these clinical audits is what is used for decision making, data-driven decision making. On the patient safety side, or the healthcare quality side, how do we collect data and how do we ensure consistency? We are a very lean team. In patient safety, we are 2 staff members. In patient affairs, which is another department and unit that collects quite a lot of data, there are 3. And then in standards and process improvement, there are 2. And so in these lean units, we've identified key initiatives to run with. And I'll give an example, like for patient safety. For the last 3 years, we've picked one initiative, which we've made it our QI, which is to reduce patient falls in the hospital and to put initiatives that will support that or will change that culture and behavior. When we embarked on that project, initially there was no data that was coming in. It was not being reported, whether there's a near miss or where there's an actual fall that happened, that was not being reported. And so part of the process or part of the work that we did was to go and find the baseline. And that baseline started with stakeholder engagement, finding out from the nursing team, finding out from the doctors, why are we not reporting? Are these things happening or are we imagining that they're happening? Why are we not reporting these things? And so that took a whole journey. I think I've used the word journey so many times. That took a whole experience for us to understand what exactly is the problem, and most of it was shrouded in fear. Fear of reporting that a patient fell on my watch. And when we went back now to look, what are the structures in place? What are the resources in the hospital? And to understand from the team, what is it that we can do to support you? We at that moment, we discovered that there was quite a lot that they felt was missing in the department or in their units and in their wards. And so starting with that data, where we had almost 0 reports, apart from where it was a fatal incident, we've improved. It's been 3 years. At least now we're getting reports that we're being informed, or they're coming and they're being documented. There's a patient who fell. There's this that happened. We are not yet where we want to be, because near slips are also things we want reported. And so this year, part of that journey, we decided to go and do an audit, infrastructure audit, and just to see what are the structures in the hospital. So for you to get consistency of data in the quality department, it has to start with you engaging the staff at the front line, because you might not be everywhere to monitor that data. And it has to be at different tiers of data. What data are you consuming? What data do you want to collect? What data would help you improve the quality and safety of your teams? And so as you monitor your hospital-acquired healthcare-associated infections, I'd like to urge you to look at the data that you're collecting. What makes sense? And how do we improve on this data? There might be these tools that we are picking. And remember, in the morning we were told, customize the tool to your setting. Because if you pick a tool that has been developed in a different setup for a different target audience, for a different population, it might not be a plug and fit into your system. So you have to look at your system. What are the things that we need to measure? And even before you start monitoring your healthcare-associated infections, what is the structure? Donor Bedian, go back to Donor Bedian, the structure, the processes, because what you're measuring is the outcome, and the outcome is a result of these 2 inputs. So if you don't look at the structures you have in your facility, if you don't look at the processes that you've outlined, if you have guidelines, if you have protocols that you've put for us to prevent hospital-acquired infections, how are we going to change our catheters? When do we change them? How do we have to ensure we don't have stockouts? Supply chain issues are cut across every facility in this room, I think. So how do we ensure that we don't have stockouts? So you have to look at your structures, you have to look at your processes before you come to measure your outcomes. I hope I've been able to address that. Maybe I could answer 2 more.
Thank you, Rhoda. We have.
There was one that was very specific about medical errors, please.
We have to end there, and we are going to allow that. The reason we have this session as well is because we can do some networking. We really, really appreciate you sharing your experiences with us. I think there's a wealth of information that we can all garner from you. I think let's arise. Let's all arise and just give a warm, warm round of applause and also take a break. Because of time, we really have had to cut short, but that's a good story.